welcome to the September 2021 BJA Broadcast. I'm Phil Hopkins, I'm from the British Journal of Anaesthesia, and I'm delighted to introduce to you Karen Domino and Rachel Douglas, who will tell us a little bit more about themselves in a moment. But first of all, I just want to share with you the title and details of the publication that we're going to be talking about today. There's a QR code that if you scan that onto your device will take you to the article on the web. And the title is Communication Failures Contributing to Patient Injury in Anaesthesia Malpractice Claims. Now, as anesthesiologists, we are all intent on providing safe care for our patients. Unfortunately, mishaps do occur, and we'd love to see them not occurring. But one of the ways that we can address this issue is by analysing what contributes to harm or mishap to the patient. And I think this is an incredibly interesting area that many anesthesiologists and anaesthetists will be wanting to find out more about. Some of us may not feel that anaesthesia is a specialty that good communication is required. After all, our patients are often asleep, but actually we're part of a really important team working environment. So, hello Karen and Rachel. Would you just like to tell us a little bit about yourselves?
Sure. Hi, I'm Karen Domino. I'm a professor and vice chair for clinical research at the Department of Anesthesiology and Pain Medicine at the University of Washington in Seattle in the United States. I have always had a big interest in adverse events. I think partly as an experience that I had as a young resident and learning from adverse events. And I've been a primary investigator for the Anesthesia Closed Claims Project for over 20 years. And that's funded through the American Society of Anesthesiology.
Okay, Karen, we'll come back to the Closed Claims Project and what it is in a moment. But Rachel, hello.
Hi, yeah, my name is Rachel Douglas, and I was a resident at the University of Washington Department of Anesthesia, and while I was there, I was a John Bonica Research Fellow. Dr. Domino was my mentor during that time and still is. And I've been very thankful to have a position on the team at the Closed Claims Project. I currently am in private practice in Ithaca, New York, and this upcoming July, I'm going to begin Regional Anesthesia Fellowship at the Mayo Clinic in Rochester, Minnesota. And yeah, I've really appreciated being a part of this project, and it's really helped form me into the care provider that I am today.
Great. Okay, well, let's talk about the paper. And Karen, you said you've been a senior investigator in this area for 20 years. What persuaded you or what interested you in looking into communication failures as contributing to the claims?
Well, I think largely that's come from my experiences in quality improvement and communication problems among our team members, with surgeons, communication during handovers. All these things do contribute to adverse events that patients have and patient injury. So I was really interested in looking at it in the claims. These are different than you would often see from just quality improvement type of events in the hospital. So that's why I was interested in this. Okay,
and Rachel, for you, was this something that was an opportunity, or is there any particular interest in communication, good communication and poor communication in your practice?
Well, it was an opportunity, and yes, there is interest, very much so. For me, when this project came up, I was just at the end of my intern year and beginning into my CA1 year. And that's really a formative and somewhat intimidating time when you're really figuring out what your place is on a team and you're trying to integrate your knowledge and really stepping into the role of a patient advocate, but really trying to figure out how to do so in a socially savvy way that people hear you. So yeah, it's been a very formative part of my training, and even in private practice, I've still gone on to do communications work right now. We formed a committee at my hospital, a communications committee actually, where we're looking at exactly this issue, how to improve communication among the operating team.
Thank you.
Mm-hmm.
So Karen, now to you, and back to the closed claims project. Now, I'm sure all anesthesiologists in the USA will be quite familiar with the project and all the work that you and your colleagues have done over the years. For the rest of us, can you just give us a little bit of background about it?
Sure. The closed claims project was started in the mid to late 1980s, and it was started as part of an initiative by then the president of the American Society of Anesthesiologists because of a medical liability crisis, and decided the best way to reduce malpractice and malpractice costs is to improve patient safety. His name was G. Pierce. And so my previous department chair, Fred Cheney, was head of the liability committee at the American Society of Anesthesiologists. And he was given the task of trying to come up with a project that would then be viable. So that's really how it got started. And it's been funded since then by the American Society of Anesthesiologists. And in the last 5 to 7 years, they have the Anesthesia Quality Institute, which is a sort of the quality and safety component of the American Society of Anesthesiologists, and that funds the project.
Okay, so these are cases of malpractice, negligence that have been resolved in terms of a conclusion one way or another. Is that right?
That's correct. What we do is we contract with a variety of malpractice insurance companies. And once these claims have been closed, they've been resolved, there's either a payment or not a payment, they then allow us to come in to their companies and review the claim files, which include medical information, as well as a lot of legal information as well. So you get a very broad amount of information in these claims. And we think they insure about somewhere between probably about 60% of the anesthesiologists in the United States. So it's not everyone who's in their claims, but it does represent a large proportion of claims against anesthesiologists in the United States.
Okay, so how many new closed claims would come through to the project every year, typically?
Well, in terms of ones that we don't collect data on all the claims. For instance, if some of them seem to be more surgically related, or if the anesthesiologist is dropped, we may not collect any data because there may often be no information there. But we would collect generally around 350 claims per year. And these include both an online data collection instrument. It basically took away 22 pages of checkboxes. And what's also really critical for this project is we asked the on-site anesthesiologist reviewer to write a summary detailing all the type of events that might have happened. And we've been doing that in a lot of our more recent studies, is using that in a qualitative analysis to come up with issues such as communication problems.
Who are your anesthesiology reviewers? Are they people local to the case, or?
No, they're generally people who volunteer to serve in this regard. There's board certified anesthesiologists who are members of the American Society of Anesthesiologists. There's a core group of about 20 individuals who've done the reviews. And we often have them, many of these folks have been on the boards of the malpractice insurance companies, which is why we can often get into their company to see these files.
Okay, so you've got experts who are collecting the data and deciding what data is relevant and entered into the database.
That's right. And there's as they were saying, there's the qualitative, the summary component, which is important, but there's a very large number of other data fields that characterize demographics and type of anesthetic and type of problems that arise and liability information.
Mm-hmm. Great stuff. Okay, so let's get on to this paper now. Now, one of the really interesting aspects of your work is that you classified different types of communication failure, which I found was absolutely fascinating. Can you tell us a little bit about that?
Sure. We've approached a number of these, I mean, the really human factors kind of topics of communication, or as an example, by trying to look at what's available in the literature. And in this case, social scientists do a lot of the work on communication. There was a study we found in doing our literature search about it by Lingard et al., published in 2004 in a journal that most anesthesiologists don't read. And it was a quality and safety and healthcare journal. And they did observations in an operating room, of team observations of the whole surgeon, anesthesia, and nursing team. And they came up with this classification system as far as communication problems. And we incorporated that in this study to have a framework that allowed us to know, with definitions of what type of errors these were.
Mm-hmm. Okay, and I think you have a slide that can illustrate.
Yes, I do. So this is an example that shows, I don't know if you can see my pointer on your screen, but
certainly can, yeah.
Good. So the project database is the total number of claims in the database. And at this time, there were over 10,000 of these claims. We now have over 11,000, another 1,000 claims, if not more, in the database. What we did is we looked at claims we call perioperative, and these were inclusion criteria, which were surgical, procedural anesthesia care, acute postoperative pain anesthesia care, obstetric anesthesia care, and that these were included in it. We also do have chronic pain medicine claims, and we did not include that in our study. And we looked at ones from where the event, the injury, the patient injury and adverse event occurred from 2004 to later. It roughly, in the United States, these claims often take up to 5 to 7 years to be able to close. And our latest type of a year of the event was 2013 when for this data set. We had then over 1,000 claims that met this criteria. And then we had 3 of our authors used the Lingard system, and we classified whether there was a communication failure in this. Now, some communication failures were simply one of involved in the liability or the legal aspects of it. And such as example would be having an incomplete anesthetic record, having problems at a deposition, having wrong information in your, or forged records and those we did not look at these, but we then categorize those that were related to, there was communication failure that has caused this patient injury or was associated with the injury. And these represented about 43% of the type of the claims during this period of time, compared to those that didn't have a communication failure. When we looked at the root cause, and these were, we also again used inter-rater reliability tests in order, we can see our kappa value was quite excellent, as we relied on our definitions from the Lingard et al. Study, that content was one of the biggest issues. And what we would say for content, it's really not describe, not passing on information that you need to pass on. Example of this might be someone is a Jehovah's Witness and doesn't want blood during the procedure and this information is not passed on to, say, a partner who's taking over a case. So content was the one that's the biggest problem. We also had several other types of categories. Purpose is one where there's some disagreement between often the surgeon and anesthesiologist over what a management of a patient. It also includes rude, disruptive, and bullying behavior that involved as well. Audience is when someone is not present. They may be physically present, but not really paying attention to things. And an example, this might be during a preoperative timeout procedure where you're trying to discuss the patient, their allergies, their type of what the surgery is, and having a key team member, such as an attending surgeon, not be either present or not paying at all attention or participating in that team, important team interaction. And occasion just means that the timing was inadequate for it. So oftentimes this relates to test results that come later than before the procedure. So these are the things we categorized.
Okay.
I'll just point out one other thing, since I have these on, and then get rid of my screen sharing, that we interact with a lot of folks, anesthesiologists do, and about half of these were during the procedure, but we had pretty much equally divided between pre-procedure issues, which can deal with problems with consultants, for instance, and other primary care physicians or providers, and their ones of post-procedure, which may also reflect interactions with your ICU team, or perhaps the surgeon, or in acute pain medicine. So the type of communication failures did occur throughout a continuum of anesthesia care. That is kind of basic description of what we did.
I was muted there. That was really helpful, Karen. And looking at all the cases that were collected, I presume that there's quite a spectrum of level of injury that the patients experienced.
Yes. It ranges from, well, let me just say, first of all, malpractice claims are the worst of the worst injuries. So we really, it's like I always use it, the tip of the iceberg of patient injuries. These are often ones that are severe and permanent. They include death, severe permanent type of injuries such as brain damage. So they did, and that's the study of malpractice claims, is it does tend to focus on that very severe sort of injury. But we did see that these communication failures resulted in all types of injuries.
So
observational studies say there are communication failures, and often there are just workarounds and no patient injury. So we focused on the injury, the really bad claims.
Were there any of your findings that you weren't expecting?
We had a surprisingly higher proportion of communication failures occurring in ambulatory or outpatient settings. And these were, we know that these are often healthier type of patients having procedures, smaller procedures. I always think, that I had the impression that, gee, these communication failures are more likely in, say, emergency procedures, or more likely in complex cardiac procedures or neurosurgery or trauma surgery or that. And that was surprising for me. And we don't know exactly why, but I think part of it is, we have a lot of ambulatory centers in the United States. And also many of them, it may be difficult to communicate with their primary care or their surgeon or other consultants in this circumstance. Also, a lot of them, the regulations, well, I don't know, I see this from, I'm on a state medical board. And a lot of times some of the providers who work out of these centers don't have the same credentialing process that hospitals do. So you may get some personalities that may not work in a hospital that are different. I'm not exactly sure. So that was a surprise to me. How about Rachel? Did you have any finding you thought was?
That was also surprising to me, that a lot of more of the communication failures happened in an outpatient setting, ambulatory surgery center, and that it was more often in healthier patients. And it was interesting, just like, in our literature review and seeing what else other people have found. One of the things of note is one of our co-authors, Dr. Posner, she published a paper that was looking at behavioral practice violations and surgeon critical claims. And one of the things that they noticed in their paper as well was that a lot of the behavioral violations in these claims were with patients who were healthier. They were the ASA 1s and 2s. And I think that really poses a good question for future areas of research as to why, like, what are some of the interplays that is happening there? Some maybe the system that we can be looking at, like production pressures and things like that. And then another thing that I thought was really interesting was handovers. There's been so much research published on handovers, improving the handover process. And I thought that would be a lot more prevalent in our research than it was, although we did find some of those failures. But I think we talked about that in our paper, that may just be more of a circumstance of the claim more focusing on the critical areas of failure rather than the systems issues implied within a handoff.
Interesting stuff. A
Mm-hmm.
lot to learn, I think.
Definitely, yeah.
Now, one of the aspects of your paper that I really enjoyed was your little case vignettes. I just wonder if each of you could share the cases that really stood out for you.
Well, I'll just start. I think these vignettes are really interesting, because that's where I'm saying the summary makes all the difference on that. And the numbers we otherwise provide aren't as interesting. So one of the cases I found most interesting was the patient who had a perioperative stroke. This patient was on warfarin preoperatively, and that was held by the surgeon and the patient's primary care. The anesthesiologist then came and saw the patient the morning of surgery and decided that the patient, based on the patient's history, that the patient needed to have further cardiac workup because he was concerned about the potential of angina. And in the whole process of arranging this then, and of course discussing with the surgeon about canceling the case, postponing it, and doing it at a later time after this workup, what happened is no one told the patient to resume the warfarin. And patient now had been off for over 2 weeks by the time the patient was rescheduled after a negative cardiac workup, by the way, and had a perioperative stroke, which was devastating to the patient. So that sort of thing, it really makes this whole communication between one's primary care or cardiologist, the surgeon, and the anesthesiologist, and nursing, and the patient's family are really, really critically important. And so that case, I was really shocked by that case, but you can see how it can happen.
Yeah, I'm really not surprised that one stuck in your mind. What about you, Rachel?
So there are quite a few impressionable cases, of course, in this project, but one of the more standout ones was it was a case in the ICU where an anesthesiologist was called for an intubation of a patient, and they were consequently intubated by a non-anesthesia provider. They were coding, and the anesthesiologist was uncertain, not convinced that the tube was placed correctly. And he challenged them and announced his concerns, but he was not received well, and they were insisting that the tube was in the right place, and he consequently left, and the patient did die, and they did find that it was an esophageal intubation. And I think this case is really interesting for a few reasons. Most notably, you learn in the team steps training, there's the cuss words, that you say, I have a concern, this is a patient safety issue, etc. And when you announce those, it's really supposed to be a stop moment. And whomever the receiver is of those is really supposed to stop and think and realize that they're being checked. And in this case, that wasn't received well. And that tool was not it was executed, but it wasn't received in a way that helped with the result. And at the same time, there's another team steps tool called the 2 challenge rule. And that's where you challenge somebody, it's twice, and if they aren't responding, then you kind of take over. And I don't know if he had really stepped in more in this case, if there would have been a different result, but I think that, it has more of a global awareness of the implementation of the use of communication tools and how it can really speak to our role.
Okay, so do you have formal communication, teamwork communication training for anesthesiologists, for all doctors in the States now?
I think it depends on your center. I can tell you that we did all undergo team steps training, maybe five to 6 years ago. And that, I think all throughout the United States, we do have our perioperative checklists, which involves the surgical team, the nursing team, and the anesthesia team, which, based on the WHO surgical checklist, that's everywhere. But as far as the type of specific training is sort of hit and miss.
So is that something?
How about you? Yeah.
Is that something that you think that we should learn from your study, that where that type of training isn't routine, it should be implemented?
I really do think it should be. I think trying to, and I'm involved in training residents as well, and fellows, and there's a whole system that you need to learn to develop good communication skills, and that should be done, I think, throughout the U.S. The part of the problem with the training is that it's comes down how much you learn and retain a year or 2 years later is certainly less, and so it may need to be repeated which people get tired of having repeats. But that I do think it is important to be able to learn how to communicate well and deal with like the situation that Rachel discussed, because we see that all the time where anesthesiologists are not able to respond to particularly a nasty, bullying and belligerent surgeon or ER docs or GI doctor or whatever. And I think that sort of thing is really important to learn.
Yeah, one of the things that I've observed in my practice is that communication within teams, between teams, has generally improved, is my subjective opinion. And I guess that reflects the promotion of the type of training that we've been discussing. Now, you started your data collection for this study 2004 and went on essentially for 10 years. Were you able to gauge any sense of improvement or change in the types of communication failure?
Well, we really weren't. I mean, part of the issue is we don't have denominators for it. I mean, it's so that it's hard to be able to look at the sort of trends over time. I think as a clinician, I think we've now incorporated more handoff protocols and more electronic data uses that do, I think, are helpful, as well as more training. So I think over time it has improved, but these adverse events still occur. I mean, just as an example, I'm on my state medical board, so I hear about adverse events, and we still have on-patient fires from the electrocautery and oxygen use, with people not communicating about that, not discussing a fire risk. It still happens. Disagreements still happen. Rude behavior happens. So I think things have improved, but there's still room for further improvement.
Yeah.
Okay.
It's been interesting from my perspective, going from academics where we all had team steps training and then out into private practice where there's people that have been in practice for 20, 30 years and they didn't have these kinds of communication trainings as part of their background. And so feeling heard in those situations, and like my hospital currently trying to, thankfully, have an acknowledgement of the need to improve the communication and how that creates a better functioning OR environment for everybody. And it's nice to see that, and it's nice to be a part of that. Yeah, I feel like for me it's been interesting, and as far as the research goes, I'm kind of excited to see more research in how we can still improve the communication setting beyond just handoffs and surgery checklists and those sorts of things, which are incredibly valuable. Like the WHO study came out, I think 2008, which is in the middle of all of this, and that decreased post-operative mortality by 20-something%, and that's incredible. But what else can we do, and how can we continue to fine tune our ability to create well-functioning ORs centered around patient safety?
Okay, thank you. Karen, perhaps the final word to you on that.
In terms of
on what we can learn from the data in your study and the scale of the problem and the types of problem.
Yeah, I think, again, I always like these sort of case stories. I think a lot of times we learn from these better than we do from, research article or that sort of thing. And I think trying to really collect more data about it on a broader level would be really useful to be able to have, and show the physicians and the nurses and teams about how we can actually improve all of our care of patients. So I think, again, more data collection in a broader sense standpoint would be really helpful.
Yeah.
Perhaps a NAP focus on communication would be, since, something that in UK you could do.
Yes, the national audit projects of in the UK have been a great success, and certainly there's none of them, I don't think, that's really incorporated any aspect of communication or communication failure in elucidating the poor outcomes that have been the subject of the respective reports. We may take you up on that, Karen.
Yeah, I think you guys are all poised to be able to follow up with a really fascinating study.
Mm-hmm. Mm-hmm. And I entirely agree with you in terms of learning from the exemplar cases, such as you've published in your paper. Unfortunately, a lot of people will submit case reports for journals, but very often when they submit those that went well.
Yes.
And it's going to be the very brave clinician who's going to submit a case report where they did things not so well.
That's right.
But having some form of database or review of the claims in a similar way to your fantastic project would, I think, be really educational.
One of the other things I think would be really interesting to see is more multidisciplinary studies, like looking at, simulation trainings that involve not just the anesthesia team, but the surgeons and the nurses, and how does that really improve the culture? Because I think part of it is just respect for each other, and actually learning the roles that everybody on the operating team has, and the courage that it takes to speak up within the OR, and being able to stop and respect that, and give value to what is being said in that moment. I'm looking forward to seeing a little bit more of that. And coming from my side and in the private practice world, it's like, well, how do we do this? Like, how do we do communication trainings, and what is important, and how do you do it in a successful way? And I think, like, not doing it just at your department meetings, or having something that is more like communal, and it would be very interesting.
I certainly second the interesting aspect of it. Yes, trying to get some of our non-anesthesia colleagues into scenarios and training scenarios like that would be great fun. Okay, well, thanks very, very much to Rachel Douglas and to Karen Domino for discussing their paper in September's issue of the British Journal of Anaesthesia. We hope you've enjoyed the discussion, and it's illuminated the work that Karen and team have done and have been doing so usefully for our specialty and for patients over the years. Karen, Rachel, thanks very much.
Thank you.
You're welcome. Bye-bye.
Okay, bye from all of us. Bye-bye, and thank you for listening and watching.